More than 5 million Americans have heart valve disease. However, some people never have symptoms, and others may dismiss them as a part of aging.
Once diagnosed, this heart condition can be successfully treated. That's why early detection and diagnosis are so important.
We will provide important information about heart valve disease on this week's Health Talk. We're up next. Hello, I'm Dr. Vicki Smitak.
And I'm Dr. Eric Mazer. Today we're going to discuss cardiothoracic surgery and valvular heart disease with Dr. Robert Gallagher. He's Chief of Cardiothoracic Surgery at Western Connecticut Health Network. First time on the show. Welcome, Robert. Glad to have you.
Thank you very much. Glad to be here.
So it's a big topic, heart valve disease. It could be a natural part of aging. It could be part of different syndromes. It could be a whole host of different things. Tell us a little bit about, first of all, maybe we can just start with basic anatomy. Where are these valves? Where do they sit inside the heart? Why are they important, and what happens to them?
Sure. There are 4 valves in the heart, 2 on the right side, 2 on the left. The heart can be divided into basically an upper and lower chambers. The upper chambers are referred to as atria. The lower chambers are ventricles. There are valves that sit between the atria and the ventricles. On the right side is the tricuspid valve. On the left side, that's the mitral valve. And then the 2 other valves are the pulmonic valve and the aortic valve. The valves that I really want to concentrate on today are the 2 left-sided heart valves, which are the mitral valve and the aortic valve.
And those valves are important, aren't they? Because as the heart squeezes, you want the blood to go in the right direction. And so if the blood's coming in from one side, you want it to go out the other side.
Exactly right.
Basically, as in a very simplistic way.
Right.
Yeah, I mean, the valves are, I mean, they're very sophisticated, but they're very simplistic in the sense that they do allow unidirectional flow of blood through the heart by simply opening and closing and ensuring that as the blood enters each chamber, it continues to move forward and doesn't go backwards, and it can move forward without a lot of restriction of flow.
So that's what we mean. So when valves are damaged, Robert, or when they're not working anymore, what exactly does that mean? And it could mean a couple of different things, but ultimately, what does it mean when the function is no longer good?
Well, when valves start to fail, they fail in one of 2 ways. They either become narrowed, which is referred to as stenosis, or they become leaky, which is referred to as incompetent or regurgitant. The aortic valve usually has a problem with stenosis. That's the predominant pathologic condition that it suffers from. Most of the time, aortic stenosis is a result of a calcific process that occurs as sort of a process of aging. People can develop aortic stenosis if they have 2 leaflet valves instead of 3 leaflet valves, which is something that they're born with. That tends to present at an earlier age. The mitral valve doesn't often become stenotic. The only time we see stenosis of the mitral valve is in patients who have rheumatic disease. And rheumatic disease in the United States.
Rheumatic fever, not.
Yeah, well, they started out, they had untreated strep infection as a child,
right,
resulting in rheumatic fever, and then later on it affected the valves, and over time the valve becomes thick and stiff. It's, when you look at those valves, it's very characteristic that this is a patient who had rheumatic fever at one time. So that's rarely seen in this country. It is still seen in underdeveloped countries. Usually those patients present much earlier. They present in their 30s. The problem
is, I saw a case of acute rheumatic fever as a medical student in Baltimore. I have not seen one since. So it's really.
I can't say that I've seen
one. And she's a as a pediatrician.
Yeah.
It's become such a almost non-existent disease in this country.
Well, now with rapid strep tests, people can diagnose it early, get put on appropriate antibiotics, and so yeah, it's something that we don't really see. The problem with mitral valves really is a regurgitant lesion. It usually results from
leaky. You said that. But
yeah, mitral valve prolapse is the most common thing, and the medical term for the disease process that results in the prolapse is fibroelastic deficiency. Basically, what that means is the fibrous tissue and the elastic tissue in the valve and in the supporting structures under the valve become sort of stretched, so that the leaflets can't coap.
It's sort of what happens to our skin as we get older, right?
Sort of, yeah. If we could pull up the graphic, we could show you a little bit about what that valve would look like. If you look in the upper right corner there, it's a little bit dark, but you can see a valve that looks like it has two pieces of tissue connected by some strings underneath, and that is the mitral valve. That valve should open as blood returns from the lungs and allow passage of blood into the left ventricle.
So actually, that's in the heart with those two jellyfish that we're seeing on the right side.
That's right, in the heart, and then the major muscular chamber that you see there is the left ventricle. So blood comes back from the lungs, passes through the mitral valve, and then once the heart contracts, it pushes the blood out through the aorta and out through that aortic valve. That particular image demonstrates a aortic valve that's become calcified and stenotic, but it also is a good representation of the mitral valve, which has the little chordie underneath. I often tell patients a mitral valve looks like a parachute that's sort of been cut in half. Blood hits the dome of the parachute and comes down, and when the heart contracts, the parachute billows back up. The strings need to hold, and if that anatomy is altered in any way, either the two edges of the leaflets are pulled apart, or one leaflet rises above the other, that's when you get a regurgitant valve.
So what really happens then, again, for our viewers at home, regurgitant means that the blood flow, you're getting backflow basically,
Backflow,
right?
exactly.
So the valve is not competent enough to push, to keep the blood from backflowing, and it's backflowing back into that chamber.
If you think about the mitral regurgitation, the blood, rather than going out to the body through the aorta, is sort of being pushed back towards the lungs.
Sure.
And
so that gives you all the symptoms that we're going to get to in a few minutes, as opposed to the difference between that, and I just want to make sure that we're really clarifying it in sort of basic terms, versus stenosis, which is a narrowing, like you said, which is the heart is trying its best to push that blood through, but the valve is so narrow that it can't get through, and that's the difference.
So they're trying to breathe in and out through a straw.
Exactly.
You're not going to more
That's
resistance.
a good analogy, actually.
Yeah, it's probably easier, probably more sucking than blowing, but it's still.
Right.
Are we seeing more valvular disease now than we did 30, 40 years ago because people are living longer? Or has this always been there and we're just diagnosing it better?
I think it may be a combination of those two things. I think there's no question that valvular disease is seen more as we age. So with each passing decade, from the 50s on up through 80s and 90s, the percentage of individuals with valvular disease goes up. It can be, if you're in your 40s, maybe 1 or 2%. If you're in your 80s, it could be as high as 15%. The tests that we use to diagnose valvular disease, though, have become more sophisticated as well. So we're detecting it earlier. So it's hard to distinguish how much of it is an increase in the percentage of patients that are getting it versus actually picking it up at an earlier point in time.
Is it usually diagnosed based on symptoms or patients
I was just going to get to that. Yeah.
Right, or is there a way to diagnose it, to your point, before it actually before the patient becomes symptomatic?
Yeah, oftentimes it's picked up by a primary care provider that hears a murmur, and then they send the patient and the patient may say, I don't have any symptoms, I feel fine, and they say, well, let's just get an echo and check it out and see where the murmur is coming from.
So a murmur is an abnormal sound, or a sound that maybe wasn't there before.
That's right. I mean, normally when you listen to a heart, unless there are some murmurs that are called functional flow murmurs that are just in people that have such strong hearts that the amount of blood that gets pumped out, called the stroke volume, is so great that it can actually tumble a little bit as the blood moves forward and creates the sound of a murmur. Sometimes you see that in pregnant women. They have an increase in cardiac output because they're pregnant, and they develop murmurs, but there's nothing wrong with their valves.
It's just children,
it's just a functional
children,
murmur.
Anemic patients will sometimes do
anemic
that.
Patients as well, yeah. But the vast majority of people who have murmurs, they're usually pathologic, and they usually come from an acceleration of flow through a narrowed orifice when you're speaking about a stenotic valve. And then in the mitral valve, it's not narrowed, but the blood tends to tumble as it goes backwards through the mitral valve. And that tumbling and sort of swooshing sound that we hear is the murmur that we pick up when we listen with our stethoscope.
I think you could think of a river flowing smoothly between its banks, and then a narrowing, and it gets tumbled up and gets noisy.
Turbulent, and creates eddy currents.
Yeah.
Yeah.
I wonder, would you say most referrals are coming in based on clinical exam and hearing a new murmur, or is it more symptomatic patients who are saying, hey, I'm having some issues with my breathing or chest pain and what have you?
It's probably, the onset of symptoms often is later in the course of the disease, and I think we're getting better and better about picking it up early.
That's great.
So I think the primary care docs are hearing murmurs, or maybe sometimes a patient will complain of a little shortness of breath, and they'll say, well, let's just do a little further diagnostic study, and let's get an echo and let's get a chest x-ray and see if we can figure out why you're a little short of breath. But I would have to say most of it is picked up early and before the patient even has symptoms.
And that's really important because, as I know you discussed, the heart begins to change under these stresses. It remodels, it gets, the left ventricle gets thicker. You could actually get heart damage from prolonged leaky valves or stenotic valves.
That's right.
And so you want to catch them at just the right time. So maybe you could tell us a little bit about the different symptom complexes you see with mitral regurgitation and aortic stenosis. So that's the leaky valve between the two chambers, and that's the stenotic valve. Aorta is the stenotic valve at the end of the left chamber that pumps into the body.
Well, with aortic stenosis, there's sort of a classic triad of symptoms. It's shortness of breath. It's also dizziness, or sometimes if the patient has a decrease in blood flow to the brain, they can actually faint because during exertion, not enough blood can get through that stenotic valve. And the last thing is chest pressure or chest pain. So those are the three sort of cardinal symptoms.
And those are, by the time you get there, it's really late, isn't it?
Yeah, you've usually, once you become symptomatic, I mean, they showed even back in the 1960s that there can be a very long latent period where patients are asymptomatic, but once you develop the onset of symptoms, the mortality over the course of the next 2 years rises significantly.
And we have just a brief few moments left in this segment. You said talk about the mitral valve, why people get shorter breath with the mitral valve, and what happens to the lung and the vasculature.
Yeah, a lot of it has to do with sort of the back pressure that's created. So, as we mentioned earlier, blood should flow through the heart in a unidirectional fashion, and so if there's a backwash of blood into the left atrium, which is the chamber on the other side of the mitral valve, that pressure is transmitted back into the lungs, and as it goes back into the lungs, you get high pressures in the lungs. Eventually, you can actually get fluid that is sort of pushed through the lungs and ends up in the lung tissue, and the patient can get short of breath because now there's essentially water filling the lungs.
So that these defects really have significant secondary sequelae. And so that's all we have time for now, but when we come back, I think we'd like to talk a little bit about how the diagnosis is made and then how you can correct it,
surgery,
which is so exciting. And so we'll be back after this short break. Hi, we're back with Dr. Robert Gallagher, cardiothoracic surgeon, sort of the pinnacle of surgery, as everybody everybody talks about. So we were talking a little bit about valvular heart disease. When should someone? How do you decide when someone actually needs their valve replaced?
Well, as you mentioned earlier, valvular heart disease is being detected earlier and earlier because of the ease of access to an echocardiogram. An echocardiogram really is the primary diagnostic tool that we use to diagnose valvular problems.
That's using sound waves to image the heart. So
it's an ultrasound.
That's right.
It's an ultrasound of the heart. It's it's benign. It has no radiation exposure, and the pictures are amazing.
The pictures have gotten better and better over the years. Most of them are what we call transthoracic, meaning it's done on the surface of the chest, and you can get very good images. Sometimes people with emphysema or very large chests might not image that well, but the vast majority of people you can do an external echocardiogram and make the diagnosis. If patients are found in an asymptomatic stage, and they have mild to moderate disease, they're just followed, and probably their primary care doc or their cardiologist would recommend that they be followed annually with echoes. As the disease gets more severe and or the patient becomes symptomatic, you reach a point at which the doctor will say, well, we think your valve needs to be addressed surgically at this point in time because we've followed it as long as we possibly can.
So these valves, so when you say approach surgically, we're talking about replacing these valves, right? These valves are no longer, they're not fixable, right? And you have some props that you're going to show us when we talk a little bit, or you can show us now what an actual valve looks like, a replacement valve, if you will, because this is really neat stuff. It's actually really neat for me to see it sitting here on a table. So maybe we can do that, because this will be very fascinating for me as well.
Sure.
You can show us what it looks like, and we can get a close-up for our viewers at home.
Yeah. The aortic valve, they tried decalcifying it years ago, and it didn't really work. I mean, it worked in the immediate perioperative period, but long-term it didn't last. So the only time you can repair an aortic valve is if it's a leaky valve. Sometimes you can actually address what the problem is. You can either tighten it, or if there's a prolapse leaflet, you can pull it up to its proper orientation, and so you can fix that valve. Or if there's an aneurysm, an enlargement of the aorta around the valve, you can replace the aorta and then put that valve back inside the ground.
Open heart surgery.
Open heart surgery, exactly. Right. But by and large, almost all aortic valves need to be replaced. And there are two basic categories of valves that we have. The one I have in my right hand is referred to as a bioprosthetic valve or a tissue valve. This particular one is a bovine pericardial valve. So that's a valve that comes from the heart sac of a cow. It's constructed to look like the original aortic valve. It has 3 leaflets that open and close very similarly to a native aortic valve. It is mounted on a metal frame, and then the entire thing is covered with a cloth.
So that entire thing, Robert, sits inside the patient's chest.
That's right.
When you put
and
it
you
in.
sew that white ring then to the annulus, that area around the aorta, between the aorta and the left ventricle.
That's right. It's sewn. So we take the leaflets out. We debride the calcium from the frame of the valve, which is the annulus, as you mentioned, and then we put the stitches in the annulus, put them through what's called the sewing ring of the valve, which is right here, and then lower this in and secure it into place. This valve on the left is
which is the viewer's right, just to be.
Okay, is referred to as a mechanical valve. It is a bileaflet valve. It opens and closes passively with flow as well, and functions very similarly to the tissue valve in that it is flow directed. And
looks like the vents I have in my heating system at home.
Yeah,
on the floor.
That's sort of the beauty of it, is that the design is simple, but it's so effective, and they basically are indestructible. They last almost as long as the patient will last, and the only time we ever really take these out is if they get infected. So the benefit of a mechanical valve is its durability. The downside is you have to stay on a blood thinner, Coumadin, and it does make a little clicking noise, which some people said they won't be able to tolerate. The tissue valve, on the other hand, is silent, makes no noise other than if you listen to the patient with a stethoscope, you might still hear a little residual murmur. It does not require long-term anticoagulation, but the downside is it won't last permanently. So the durability of this valve is age dependent, and unfortunately the younger you are, the less durable these valves are. So if you're 50, this might last 12 or 15 years. If you're 70, you might get 20 years out of it.
Is that because younger people are more active and that
they don't really know. They don't really know what the process is and why it's age related like that.
How do you make the decision, or how does the patient make the decision, or how do you make the decision? Is it really cut and dry? Like, are there very strict criteria saying that if you're a certain age, you get this kind of valve versus the other kind, or is it more patient preference? Like if somebody doesn't want to be on anticoagulation therapy, for example, or if they have other risk factors, you might opt to put in the other type of valve. How does that decision making happen?
Yeah, I mean, I often try to educate the patient and then let them make the decision, because really they're the ones that are going to have to live with it. Either they're going to have to live with the fact that they're going to need a second procedure at some point in time, possibly, or that they're going to have to manage their Coumadin and their blood thinning for the remainder of their life if they choose a mechanical valve.
But from a functional standpoint, they're both equally good.
Equally
good. They both
good,
do the
yeah.
same job. They do it well.
Exactly.
It's just a matter of those other things.
That's right. It's a matter of, second operation or not, or Coumadin or not. And there's been a huge move away from mechanical valves because people nowadays seem not to want to have to deal with the management that goes along with blood thinning. It requires blood tests and adjustment of the Coumadin dosage.
Right. Also known for folks at home, the brand name is Warfarin. That people may know better.
Right.
But as a hematologist, I actually don't know the answer to this question. Are there any studies going on using some of the novel new anticoagulant agents with artificial valves?
No, not that I'm aware of, and we wish that they would, because it would make I think,
because that might change the equation, because it doesn't require monitoring, and you'd think that they should work, but you don't know that at this point.
I think when you look at the number of people who have atrial fibrillation, for which most of these novel anticoagulants are used, it's far greater than the people who have valvular heart disease that might choose a mechanical valve, and so I think the companies have possibly chosen not to study them in those patients, because if they end up in the study trials that they don't work properly, the consequence potentially is the patient could have a stroke. So I think when they look at the number of patients versus the liability involved, my guess is that they don't really want to study the novel agents in patients with mechanical valvular disease, valvular replacements.
It's too bad, because it might, if it does work as well as warfarin, it would offer people a much simpler alternative.
And then avoid the second surgery down the road.
Because people in their 50s and 60s, that's sort of the in-between age. Somebody in their 40s, I almost always try and direct them to a mechanical valve, because they said, you could end up looking at 3 valve surgeries in the course of your lifetime. You really don't want to do that. Each time you go back, it's tougher and riskier.
Yeah, I was just going to ask, just how debilitating is the operation?
Yeah,
so
what's the
this
surgery
is a
like?
big operation, isn't it?
It is big, and a lot of it depends on comorbidities and the status of the heart, as the patient comes in for surgery. But the first-time surgery is relatively low risk. Primarily because we've opted to operate on these patients earlier than we did years ago, and I think that's the beauty of following
Waiting before the heart starts to fail.
That's
and
right.
trying to catch them when they're strong and can tolerate.
Yeah, following these patients. I mean, there's definitely been a swing of the pendulum back towards early detection and earlier intervention before the heart starts to deteriorate and function.
How quickly do patients go home after having a surgery like that? Yeah, because this is, we talk so much, and Eric and I have done so many shows on minimally invasive surgeries of all different kinds. This is clearly not that, and it can't be, in the setting that we're talking about, but still, everyone's interested in recovery times, and even with open heart surgery, it's not what it used to be, right? Patients are still going home probably earlier than they used to. Maybe you can talk a little bit about that.
Yep, usually the patient will go home in about 5 or 6 days. Again, some of it depends on how old they are, how debilitated they are when they come in, other problems that they might have, whether or not they develop arrhythmias after the surgery. But for the most part, if it's a relatively straightforward, low-risk valve replacement, say an aortic valve replacement, the patient will be home in about 5 days.
And we have just a few seconds left. Could you say something about TAVRs? We've done shows on this, but it's a non-invasive way to replace the aortic valve transvenously. Just say a few words about how that fits in with what we were talking about today.
Sure. TAVR stands for transcatheter aortic valve replacement. It originated back in around 2002. First case was done in France, and it was initially designed for patients who were considered to be inoperable. It was a novel way of approaching this. It's a valve that's actually mounted in what you can think of as being almost like a cylindrical wire cage. It's crimped down to a very tight dimension so that it can be introduced either through the leg artery. Sometimes if there's atherosclerosis in the leg arteries, it has to be introduced in other areas, but the delivery sheaths have become so small now that probably 95 to 98% of patients can get it through their leg. It's delivered up through the aorta and around the arch and down to the aortic valve. And when the valve is deployed, some of them are self-expanding, some of them are balloon expanded, then it sort of locks into the existing valve that's there. So the leaflets aren't removed unlike what we would
So
do.
it crunches the old
pushes it
valve up
aside.
against
The
periphery.
leaflets just get pushed apart, and the valve actually locks into that calcium in that diseased valve.
That's interesting,
we-
and that's all we have time for. Unfortunately, our segment went by very quickly, but we would love to have you stay on to help answer our viewer question this week. So this was a great discussion. I've certainly
And
learned a
we'll
lot.
take the break, and we'll come back after a short break.
Right now, we're going to also take a look at some of our future events sponsored by Western Connecticut Health Network. This week's viewer question is, what is the best test to determine if I have valvular heart disease?
And maybe I could ask you to expand that as, when should I get this test? When should I be, what's the threshold for testing for valvular heart disease?
I think the best test by far and away is an echocardiogram, that ultrasound test that we were referring to earlier. It's simple, there's no radiation involved, it's basically non-invasive, it's done on the surface of the chest, so and it gives us excellent images, not only images of all of the intracardiac structures, but images of flow within the heart and resistance to flow in a stenotic valve or backflow, as we mentioned earlier, for regurgitation. So it's the best test. So because it's so non-invasive, anytime a murmur is detected, I think a patient should have an echocardiogram, even as a baseline, because if you're going to follow that patient over the course of their lifetime, you want to know,
You want to know where they're starting from.
Where they're starting from and how it progresses over time, and know when to intervene, because you never want them to fall off the cliff, so to speak.
Right.
And that's all we have time for. So thank you
Thank
so
you.
much. Very, very interesting topic. If you at home have a question you'd like to ask on Health Talk, please contact Vicki and me at healthtalk@norwalkhealth.org.
Eric and I would like to thank our guest, Dr. Robert Gallagher, for coming on Health Talk today, and we will see you next week on Health Talk.
Bye-bye.